Welcome, everybody. My name is Alexandru Mischie. I'm a cardiologist working in Montlucon, France. I'm the head of the intensive care unit cardiology in Montlucon, France. I have the pleasure to host today, along with Dr. Mirvat, Alasnag, and Dr. Goran Stankovic, an excellent webinar on bifurcations. I will simply pass the word to Dr. Alasnag. Thank you so much, Mirvat, for being with us today.
Thank you, Alex, and thank you to all the faculty that are here today and all our attendees. This is the first of a series that will be running throughout the summer, and it's on bifurcations. We're going to have two fantastic lectures. The first by Professor Jacques Monsegu, and Nicolas Amabile is the next one on DK crush. And then we have the platform open for discussion, so please feel free to post your questions in the Q&A, and then the faculty will address them a little later on in the evening. So without any delay, I'm going to invite Jacques to go ahead and share his presentation with us, and we can get started on provisional stenting.
So, sorry. Okay. Do you see my presentation? So I hope.
Not yet. Can you kindly share it one more time?
Yes, that's well for you.
We don't see it, Jack. Maybe you should retry, please.
Okay. I think it's well. Sorry. Yeah. Welcome, everybody. It's my pleasure to start this webinar dedicated to the tips and tricks in bifurcation with the provisional strategy. Thanks to Alexandru and the Tele-Cardiology working group to invite me for this session, and a great honor to share with this lecture with Mirvat, Goran, and Nicolas. My name is Jacques Monsegu from Cardio-Vasculaire Institut of Grenoble. And in background, we know that bifurcation PCI are frequent and always a challenge for us. The first step is to analyze perfectly your bifurcation lesion with the classification. Medina, you know perfectly this classification. To be sure that there is no calcification, you have to measure the angle of the bifurcation, and of course to visualize, of course, very well the side branch to be sure that there is or not osteal stenosis, the disease length of on this branch, and the myocardial volume dedicated to this branch. The second step, of course, after this analysis, is to define and to plan your strategy according to one stent strategy or two stent strategies. I propose you to illustrate the provisional stent approach with a clinical case. It's a man, 68 years old man, a smoker, dyslipidemia. He presented chest pain during effort with a stress echo positive in apical wall motion. The angio, you can see, show a stenosis on the mid-ADD just after the bifurcation of the big diagonal with a very nice bed on the two vessels with a positive FFR that confirm that the ADD lesion is the culprit lesion. So the first step is to analyze this lesion, the main branch and the side branch. You see that there is a local atheroma on the ADD, mid-ADD. The proximal diameter is a big artery, probably more than 4 millimeters. The distal diameter is around 3.5 millimeters. There is no calcified lesion. and the distal lesion is very nice. On the side branch, there is a little atheroma, just a plaque, just at the ostium of this diagonal. It's a big artery with without calcification and with a very nice distal bed. The angle is less than 70 degrees. This is very important. So you see it's 0.10 medulla lesion in the classification. We have an ostial diagonal plaque. The angulation is around 70 degrees and positive FFR on the distal LED. So we have to decide which approach. And for this patient, I think it's in favor of provisional because there is no lesion, significant lesion on the side branch. Of course, the side branch is big artery, but the lesion is very, very short. The easy side branch access is very easy because we have an angle, a favorable angle, and the side branch burden of myocardium is very, very important. So we decide this strategy of the provisional side branch stenting. So the procedure, this is an all-step procedure. First, wiring both branch, ADD and diagonal, and I recommend to always protect the side branch. After that, we are going to do the pre-dilatation to prepare the lesion. After that, we stent in the ADD from proximal to mid-ADD. We are going to do the port. After that, we open the side branch. We do a report and we assess, if necessary, with the physiology, the diagonal branch. So this is a pre-dilatation. So you see with a 3.5 millimeter balloon. And after that, you see we have a good result and we can decide to plan and to perform LED stenting. Nevertheless, and just to choose your stent, I want to remember you a fundamental rule about fractal law. Finet, Gérard Finet in France, Frenchman, showed several years ago that proximal diameter is always bigger than distal diameter. If you don't respect this law, and the risks are to create a distal dissection and mostly to shift the carena on side branch with the risk of occlusion, of course. So in your stent choice, distal diameter of main vessel has to be reference stent choice diameter. This is the first message that I want to share with you. On this table, you find the relation between vessel diameters, and in our case, you see we have on the left the diameter of diagonal, probably 3.0. The LED, distal LED is around 3.5 millimeter, and so the main branch is around more than 4 millimeter. So don't forget also to know the stent overexpansion ability in your choice. All the platforms are not equal, and you have to choose the right platform to assess your procedure. So come back to our procedure. We implant 3.5 millimeter synergy, 20 millimeter length. And with this result, with a good flow in both artery. After that, and just to explain you the malposition of the stent in the distal, in the proximal part, sorry, you see that on the distal part, just after the diagonal, there is a well stent apposition. But in the proximal part, you see that there is a malposition. We are not surprised, of course, because we just implant a stent 3.5 millimeter in proximal LED, probably more than 4 millimeters. So it's necessary at this step to perform the port the proximal optimization technique. This is a standard step, and it's mandatory in each bifurcation to perform this spot with a balloon according to the sizing diameter of the proximal part. The rationale of the port is to have a good apposition of the proximal part of the stent, to allow a straight protrusion in the side branch, and to reduce and to facilitate the side branch access and distal cell recrossing in the distal part. So this is what we can see on the bench. And you see after the implantation of the stent, we have a malapposition in the proximal part, and after the port, you see that we have a very nice apposition, and we open the straight through the diagonal branch. Of course, it's very important to care that the position of the balloon must be just on the carena, the shoulder of your balloon, just in this position. And be careful, because all the balloons are not equivalent, and the shoulder of your balloon is different according to the different technology balloon. So this is the port that we perform with a semi-compliant balloon of 4.08 millimeter. We have this result, and OFDI imaging show that we have a well-apposed stent in the proximal part. So after that, the next step is to recross the side branch, and for that I prefer to use the pullback technique and try to cross in the distal part of the stent, because with this technique you avoid to destroy the stent in front of the bifurcation. This is the recrossing, and it's very important to take time and just to be sure that you engage the distal part of the strut very easy if you have done a port in the well position. After that, the question is it necessary to open the side branch? I think yes, because especially on very big vessel, I think in the future it's possible that it will be necessary to recross and to perform a PCI in this branch. So I prefer to open the side branch. Kissing balloon, it's one solution. But generally with the kissing, we have a distortion of the proximal vessel with a deformation, elliptic deformation. And so I prefer to use this new concept of the report. You do the port, you open the side with a single balloon. After that, we do again a port. This is what we do in the case with a 3.0 non-compliant balloon in the ostium of the diagonal. We have this result, and after that, we do again a port, and you can see in this image of stent enhancement that the opening after port, side and port, we open very nicely the cell in front of the diagonal. So this is the report, and this is the final result with a FFO negative in the diagonal, 0.92. So this is what we see on the bench. This is very interesting to see that there is no malapposition with this technique, port, side, and report. No malapposition, no elliptic deformation, and no bottleneck effect. So this is very encouraging on the bench. And this is the final result without wire. So to summarize, provisional approach is preferred except in patients with complex lesion, bifurcation with difficult access and high risk of occlusion of the side branch. And of course, the provisional side branch stenting with port, of course, is the preferred approach. And if you have not a good result, you can do a T-stenting or TAP or culotte if necessary. So in conclusion, my preferred approach for the large majority of bifurcation PCI is a provisional stent technique because we respect the main vessel distal diameter. The port is mandatory, and it's very important to perform this port very carefully. I think it's necessary also to open the side branch, mostly if this side branch is big artery. The report after that is, of course, mandatory, and if necessary, you can use a second stent if it's necessary. So, and the last word from Albert Einstein, make everything simple as possible, but no simpler. Thank you.
Thank you. That was absolutely wonderful. I think we've agreed to reserve the questions till the end. So I will move on with the presentation by our colleague Nicolas. He will go over the DK crush technique.
Yes.
And we do have some questions coming up in the chat that Goran and Jacques will be answering as we go along. So Nicolas, over to you.
Thank you. Can you hear me? Yes.
Yes.
So thank you, Mirvat, for the kind introduction. Ladies and gentlemen, dear colleagues, Jacques, Mirvat, Alexandru, Goran, this is really a pleasure for me to be here with you on this webinar. And after this beautiful lecture from Jacques, I have the task, and it's not an easy one, to present the double kissing crush technique. And like Jacques, I will start, we will go through a case in order to present you the technique. So this is a 60-year-old man who was referred to our institution for a circumflex first marginal branch PCI, and he suffered from a previous non-STMI that was treated by a PCI on LAD and right coronary artery 3 weeks before. And during the initial procedure, we identified a very complex CTO lesion of the lateral bifurcation and CTO lesion of the circumflex, and some lateral wall viability and residual ischemia. So we decided to propose this gentleman a stage deocclusion, and let's go with the initial angio, and you see that's quite complex bifurcation. You see that the good part is the length of the CTO is quite limited, but on the other end, that's a true Medina 111 bifurcation, and there is no collateral flow from the right to the circumflex, so we will go with only one single access. The deocclusion process was not very challenging, and we were lucky to be able to cross the lesion with a fielder wire with the support of a Caravel microcatheter, and we were able also to pridylate. And at the end of the CTO stage of the procedure, we got this angio. So we can say that that's okay. That's a 011 lesion, Medina 1 lesion. It's not so well, that can be discussed. And then so in this case, which strategy can we use? So like Jacques did, we carefully analyzed this angio in order to decipher the best strategy. We observed that the main branch had a long lesion. The diameter of the main branch was over 2.5. We also observed that the side branch was also a large vessel that supplied a large part of the myocardium. There was a long and tight lesion. The diameter was over 2.5, and yet the mild vessel was not that diseased. We observed some mild plaque signs. Finally, and that's very important, the bifurcation angle at the ostium was over 60 degrees. So that's for sure a true bifurcation and a true complex bifurcation. So we decided to go for a two-stent procedure, upfront two-stent procedure, and use the decay crush technique. So what is a complex bifurcation? Jacques already mentioned it, but it's the definition trial proposed some criteria for identification of this bifurcation. So in case of the non-left main bifurcation, it's a bifurcation with a stent with a side branch stenosis over 90% and a side branch lesion length over 10 millimeters. That's very important, and at least two of these minor criteria, including moderate to severe calcification, multiple lesion, and bifurcation angle below 45 or over 670, a main vessel reference vessel diameter below 2.5, thrombus, or a main vessel lesion length over 25 millimeters. So that's these criteria are fulfilled in this case. So why did we choose the double kissing crush technique? Because that's a two-stent techniques that is very that is designed for complex bifurcation PCI. That's not for all bifurcation, but in case of complex lesion, that's a very good one because that creates a complete and reliable carina coverage and prevents the side branch occlusion in case of a significant osteal disease. Compared to the classical crush technique, you have got a better side branch opening, less strut distortions, a better apposition, and a facilitated final kissing balloon inflation. Compared to the other two-stent technique, it has shown to provide better clinical outcome, especially in the unprotected left main. That has to be confirmed in the other bifurcation. And I will just briefly show you the results, the latest result of the DK Crush 5 trial that compared DK Crush with provisional stenting for left main bifurcation lesion. And in this study, the primary endpoint was the target lesion failure at 1 year, and the primary endpoint was in favor, the primary endpoint, sorry, was reduced with the use of DK Crush. And you can see on this picture that over after 3 years of follow-up, we still observed a reduction of the target lesion failure with the DK Crush compared to the provisional stent technique. So that's a very good one. The DK Crush is supposed to be very challenging and quite technical, and that's true that it's maybe probably longer compared to the provisional one, but that's not that complicated. You just have to remember all the steps, and this video will show you. First, you have to wire both branch and dilate the side branch and main branch. You then implant a stent with mild protrusion on the side branch. You crush it and then perform your first kiss through the crushed stent, which lets you room for implanting the second stent, that is pot. And finally, you rewire both branch and perform a final kissing inflation and a final repot. And at the end, as you can see, you get a very nice coverage of the wall bifurcation. There is no stretch distortion, and there is no excessive protrusion in the main branch and the main vessel. And you see that the crushed part is very limited in terms of length. So when it's very complex, that makes sense to use this technique. And so that's what we did with our patient. But first, I'm a big fan of intracoronary imaging, and in order to prepare this procedure, and also because we like to do it after CTO, we performed an IVUS analysis that confirmed us that there was a disease, a diffuse disease, and that you observed that the main vessel that was not that stenosed appeared to be quite diseased with IVUS. And actually, the proximal reference and the proximal landing zone is maybe more proximal than expected. So we had a 40 millimeters length for the global lesion. The distal landing zone has a diameter of 3.4 and the prox has a diameter of 4.5. So based on all these findings, we decided to go for stenting to use at least 3 stents, because we don't have in France at the time a stent that is long enough to cover all the lesions. So we use 1 stent here, 1 stent here, and 1 stent here. So the implantation of the distal of the second marginal branch stent is not very complicated. We used a 3.5 per 20 megatron synergy everolimus stent. We picked up this one because the diameter was 3.5. And then comes maybe the more challenging part. You first implant this stent from the main vessel to the side branch, and you only let a very small protrusion, maybe 2 or 3 millimeters, and you have already your balloon ready from main vessel to main branch, ready to crush. So then the next step is to inflate your stent into the side branch, and you go for the crush. Of course, you need to remove the balloon from the side branch before crushing, otherwise that's going to be a mess. So we used the 3.5 balloon that was from the Megatron. And then you have to recross the crush stent to go to the side branch. And this point is very crucial because you have to put your wire into the more proximal strut. It's very different from the pot report technique where the wire has to cross the struts in the distal cell. Here you need to really target the proximal stent, the proximal cell. And you see that here we use, that's not a very fancy image, but I can show you that actually when we use the stent enhancing process, we realized that our wire was not in the prox, but in a distal strut cell. So we had to recross again in order, and we have to take some time to get that properly. And you see that we were more pleased with this approach, and now we can see the wire is really in the correct and appropriate position. So then we performed the first kissing balloon inflation with 2.5 per 12 millimeters balloons. And we implanted the second stent from the main vessel to the main branch with a very limited overlap. And we had to perform the first pot, and we use a 4.5 balloon, and the diameter of this balloon was based on the findings of the IVUS. And as you can remember, we observed that the main vessel diameter on the proximal landing zone was 4.5. And with that, you see, and thanks to the first kissing inflation, we were able to recross quite easily the different layers of struts. You see, we use a PT2 wire. We reopen the side branch ostium with a 1.5 semi-compliant balloon. And finally, we're able to perform the final kissing balloon inflation, followed by the final report. However, you see that there was an incomplete result on the side branch, so we decided to cover with an extra stent. And the beauty of this DK crush technique is that the side branch ostium is so widely open that there was absolutely no difficulty to cross the bifurcation with this stent and implant so this additional 3.0 per 16 synergy everolimus stent. That was the final result, and I think we were pretty pleased. And but as you can see, this guy has a lot of metal in his arteries. So the subsequent follow-up was uneventful with a non-significant high sensitivity troponin rise after the procedure. The patient was discharged the day after the PCA on DAPT, And we followed the guidelines, and we recommended a DAPT for 12 months because the initial indication for the DAPT was a non-STMI. So in conclusion, an upfront two-stent strategies is not mandatory for bifurcation lesion management, but should be considered in case of complex lesions. And DKK is one of the possible techniques, not the only one, but it appears to carry out the best clinical results compared to the other option. However, an excellent knowledge of the different steps and a very rigorous execution of the techniques are required to provide the best results. Thank you for your attention.
Well, thank you both for this wonderful presentations, and I think the chat has been very active throughout the presentations, but I think there are a few questions that are probably worthwhile repeating. One of them is always about the guide catheter and the selection of the guide catheter. Is it a requirement to have a 7 French guide? And I think, Nicolas, they asked about a DK crush specifically. This is one of the questions that just came up. When would you opt for something like a 7 French as opposed to our, routine 6 French?
So that's a very good point. I do almost all my bifurcation PCI with a 6 French guiding catheter, except maybe if we go for very large bifurcation in which we will use like very large stent. However, I will also, I need to say that it also depends on the type of stent that you're going to use. There is one stent on the market, and I think we can tell the name, that the current Xience is very challenging to use with 6 French. If you perform a 2 stents technique using Xience, which is also a very good stent, it's going to be very difficult to use a 6 French because there will be some frictions, and so I would recommend to go for 7 French. Probably that this issue won't be as present with the next generation of the Xience, and that's the only stent that I know with these kind of problems, but maybe Jacques or Goran have other insight.
Personally, I always use a 6 French guiding catheter, except for very large bifurcation for left main. If we want to be safe and comfortable, I think we can do the approach with the 7 French. And we like the shipless solution by radial approach. We decrease the size of the diameter of the puncture, so it's a good option. And in a small bifurcation on the very small lady, and if you do a provisional stent, you can use a 5 French technique very easily. It's possible. I'm not convinced that the 5 French by radial approach is mandatory, and I think 6 French is very safe by radial. Nevertheless, we can do provisional with 5 French.
I think it's possible, but I would not recommend to all the physicians, because then if you have a side branch occlusion and you need to perform just a kiss, that's very challenging.
Absolutely.
But if it goes well, that's an option.
Yeah, I agree with both of you. Of course, we belong to the same club. We promote the same strategy, 6 French radial for majority of bifurcation PCI. Just to clarify for less experienced colleagues in the audience, we recommend 7 French, for example, for left main with large circumflex that you will need for kissing 3.5 non-compliant balloons, and 3 wires maybe to protect 3 branches. In that case, 7 French helps you perform easier that maneuver. Otherwise, including for left main, including for DK crash, radial 6 French is quite sufficient.
And again, another question that always comes up is intracoronary imaging for bifurcation stenting. Is it a requirement? Is it a must for every bifurcation? Naturally, the answer is no, but so which are the cases that you would would insist on intracoronary imaging? Let's start with that.
I think Nicolas is someone who is preparing sessions for EBC club meetings on imaging, so I really trust that he has the most experience to discuss broad criteria for imaging.
Well, thank you, Goran. So that's a very good point. I mean, if we could do intracoronary imaging for all bifurcation, that will be really great, because I think that we could definitely improve the results. However, based that, I mean, that's not the technique is not really accessible for everybody. There is a cost, and so I would definitely recommend the use of intracoronary imaging in case you really first for left main, because that's a recommendation for both American and European guidelines, and in case of two-stent strategies. And in case you anticipate, I would say, when it's a complex bifurcation, and in case you would anticipate a problem in stent expansion, so in case of calcified bifurcation, I think that that's very important to use that. And finally, as I prepared just a session for French meeting, I was struck that in all series, the diabetic patients have a worse prognosis, even if when the technique is really great. So I think in diabetic patients, that's using intracoronary imaging for bifurcation is definitely would definitely impact the prognosis.
Yeah, Jacques, what is your personal preference?
Yes, I agree. In France, we have a problem of the cost of the procedure, and for this reason, we use not in routine intracoronary imaging. I think for the left main, I totally agree, especially when you start your learning curve in the approach of very large bifurcation with two-stent techniques, and mostly in the left. And I think it's mandatory to have a good intravascular imaging. Yes, sure, but and which one? Probably on the ADD diagonal, I think we can use OCT. It's very easy for the left main or for proximal bifurcation. I think it's better to use IRIS, because for just to see exactly the ostium of the left main, and to be sure that we have covered the ostium of the left main.
Yeah, also during the procedure, if you face difficulties or if you see that something goes wrong, the best way is to stop, perform imaging to understand what is the cause of complication, and then try to solve it based on clear understanding of mechanical problem. So this is something that we put in a consensus document from the Bifurcation Club, and I really try to have as much as possible promotion during all these webinars, especially for the left main, because I'm really convinced that by using imaging, you can significantly optimize procedural result, and by doing that, we improve long-term clinical outcome. Mirvat, many questions on pot, side pot, pot kiss, pot. I don't know who would like to start. It's interesting discussion, so but it's always the question.
I would have a question for Goran, since he started the discussion on the kissing. Yes. What would be so kissing is not that easy. So maybe if you could clarify for the kissing, what balloons should we use, at what pressure, and what is the sequence of the balloon?
Okay. Yeah. Thank you for that question. There is really a long-lasting dilemma how to optimally perform kissing, especially in provisional, because it's clear, and Nicolas already answered in the chat, for two-stent techniques, I think kissing is mandatory. For provisional, we try to focus on major bifurcations, left main, first diagonal, first big marginal branch, in which you really would like to clear the ostium of the side branch from struts. So we select balloons according to reference diameter of two daughter vessels, of daughter branches. So both limbs of bifurcation, diameter of balloon is reference diameter distal in the main vessel and in the proximal part of the side branch. We try to select, if possible, short and non-compliant balloons. Non-compliant balloons, because by increasing pressure, you control better diameter. You try to align proximally two balloons with short proximal overlap, if possible, and ideally only in the polygon of confluence, the biggest diameter of bifurcation. If you go more proximal, then you create oval-shaped deformation in your stent proximally. So it needs to be corrected by second pot. When you start inflations, we usually recommend, and this is strictly based on bench testing data. I will be happy if Nicolas one day provides some clinical data as well. But clearing of the metal from the ostium of the side branch was best achieved starting inflation of the side branch balloon first. We go to moderate pressure, 8, 10, 12 atmospheres. We don't need high pressure. Then we start inflating the main vessel balloon. We keep balloons, if possible, if patient tolerates, for 20 to 30 seconds, and then we simultaneously deflate. So we start inflating asymmetrically. We start usually by side branch, then we inflate main branch, hold pressure 8 to 10 atmospheres, 14, depends. You see on the angio if both balloons are fully open. You keep balloons inflated, if possible, 30 seconds, and then simultaneously deflate. It's very important to have a longer kissing balloon inflation, but you can also repeat 2 or 3 times shorter inflation, because the amount of recoil is huge. If we keep balloons inflated for less than 20 to 30 seconds, we have 30–40% recoil of the stent. And you know, in everyday work in the cath lab, you ask nurse start inflating, she starts, then you start inflating main vessel, 1, 2, 3, deflate, and usually lasts less than 10 seconds. So we learn from imaging again in the bench. IVUS in the bench showed us huge recoil for short balloon inflation. So short balloons, non-compliant balloons, moderate pressure, asymmetrical inflation, longer inflation time, and then simultaneous deflation should be contemporary way to perform final kissing.
And I think that takes us to the next question, which is very automatic, which is, so pot, kiss, pot, or is it pot, side, pot? What are your thoughts on that? And I think we'll just go through the panel and see what your thoughts are.
Yeah, personally, I think for a large majority of bifurcation, small bifurcation, we can use the pod side pod. For very large bifurcation, but especially for the left main, I prefer to do a kiss as Goran explained us. Very nice kiss. It's always difficult to kiss during a long time in the left main, but if possible, I prefer, and with the kiss we place the carina just in the center of the vessel, and for me it's very important. So for small bifurcation, I think we can use the pod side pod. For really big bifurcation, especially the left main, I prefer to use a kiss. But at the end of the procedure, I finish with a final pot after the kissing, and just not to be distal this second pot, just head. It's very important.
Yeah, thank you, Jacques. I think it's very important. You mentioned in your comments that simultaneous balloon inflation puts carina in the center, and for the flow pattern in bifurcations and shear stress, it's very important to have central carina position because it works as a flow divider. So I think KISS has advantages, especially for big bifurcations. And since I was trained with Antonio Colombo, I have to say that I do almost routinely KISS. And I believe that if you properly do KISS, you achieve better proximal stent expansion, you position carina in the center, and whether or not you do final pot, it's really individual. I usually do for ostial left main final pot. I think it's important to correct longitudinal stent deformation induced by the guiding catheter or devices passing inside the stent, balloons, IVUS catheter, OCT. So I believe KISS is really good for large bifurcations, and according to computational flow dynamic studies, you really improve the pattern of flow. And if you can use imaging and identify metallic struts jailing the ostium of the big circumflex, we put also in the consensus document of the EBC that if you do imaging and if you visualize, you should do kissing to remove those struts and to improve the flow and the opening of the circumflex. I don't know, Nicolas, what is your opinion?
No, I mean, I definitely agree with both of you, and I have to admit that I almost never go for a pot side repot.
So I think maybe Nicolas froze on us.
Yeah, again has a problem.
We lost Nicolas.
Yeah, he will come back.
So, while he logs back on with us, then just still following up on the kissing, is it required to kiss for every, even in provisional? So even if it's a single stent, would you kiss? And if so, what are the cases you would kiss for?
Yeah, thank you, Mirvat. This is really very difficult to answer, and we don't have clinical evidence to strongly support. It's a combination of available data and personal experience also, because I believe that properly done kissing really improves stent apposition and improves the flow in bifurcation. And according to European Bifurcation Club, kissing is optional in provisional and mandatory for two stent techniques. But optional means what I tried to explain previously. So large bifurcation with large side branch and removing with the distal cross and kissing, removing metal from the ostium of the circ prevents future problems with access, because patient can develop in the follow-up a lesion progression distally, and if that occurs more than a year after index PCI, then you need to redo kissing in order to access distal second or third marginal branch and perform PCI. And when re-endothelization process is finished, I think you have to do kissing during the index procedure to prevent restarting endothelization at the second procedure as well. So these are my more philosophical explanations why I'm in favor of performing POT for all left main and for some of the large LED diagonal bifurcations.
Thank you so much, Goran. I would have a question maybe for all the panelists. So, how would you cross the cell in provisional, and how would you cross the cell in a two stent setting?
Yeah, that question came a couple of times in this chat also today. The main difference between DK crush and all other techniques, and you saw nice illustration in Nicolas' case presentation, when you perform crush against the vessel wall of the side branch stent, you are actually bending that stent and you artificially create already some gap at the carina because you push your stent against the vessel wall, so you disconnect stent from the carina. And when you put second stent in the main vessel, that gap still exists. And if you cross distally, you may risk of going with wire inside that gap. And then if you go with balloon, inflating balloon expands that gap and disconnects actually stent in the large segment from the carina, so you don't cover the side branch properly. That's the reason why for both first kissing and second in decay crush, it's recommended and safer to cross antegrade, to cross proximal cell. And you saw how much attention Nicolas actually performed in order to make sure that his wire crosses through the stent struts, through the crushed segment, instead of going inside the gap. And for provisional, actually for all other techniques of main vessel stenting first, you try to cross the most distal cell, because with balloon you will push metal and scaffold the ostium of the side branch using the struts from the main vessel stent. And that partial scaffolding of the ostium gives you possibility, if you need second stent, to position stent without large protrusion inside the main vessel stent. And the main difference between T-tap and culotte is the extent of protrusion of the side branch inside the main vessel stent. In T-stenting, you don't protrude almost at all. You try to fully cover the ostium, having favorable deformation that Jacques showed with arrow. By inflating through the distal cell, you really give some metal support at the ostium. Tap stenting in more narrow angle, you need to pull back a couple of millimeters inside to ensure coverage of the lateral wall of bifurcation. And for culotte, you need to go more inside to touch the opposite wall inside the main vessel. So I think that distal crossing and the efforts to do that are really worthwhile, especially if you aim to do provisional.
Thank you so much, Goran. Maybe we should go for the final remarks and final conclusions of our union. Can you, what do you advise maybe the young Goran, Jacques, Nicolas and Mirvat? What would be your advice for the young cardiologists that are following us? How many procedures should they do before they start doing themselves a bifurcation? This is maybe one question. And the last question, what are the two best techniques for a two-stent bifurcation? What, in your practice, what is the two approaches you would use for a two-stent strategies? Because there are so many techniques and people don't know where to choose from.
Maybe Mirvat can start, because she is really very experienced and didn't have opportunity to present really wonderful knowledge about bifurcations.
Well, thank you, Dr. Stankovic. No, I learn from everybody every day. I think for me, what worked for me was to make sure that I paired up with somebody who was experienced. One, the steps, particularly for two-stent strategy, are multiple, and you can easily miss them and confuse them. So it's nice to make sure you have somebody with you who is well aware of the steps, but also well aware of how to rescue branches that you're losing and so on, and somebody who is comfortable enough with intracoronary image interpretation, should you need it. So I think early on in the career, what I would say is definitely have somebody as a backup with you that you scrub in. And if you notice the DK Crush trials and so on, the operators were extremely experienced in order to achieve the outcomes and the results that they did. So what I would say is, A, pair up with somebody who's experienced. No shame in that. That is how interventional cardiology works. B, learn a technique and refine it until you're very comfortable with it before you move on to other techniques. Provisional remains the default for the majority of cases in a stepwise provisional, but be ready to use the two-stent technique when need be. And I think no harm in referring a case that you think you are not able to perform or requires a special two-stent technique that you're not particularly comfortable with. So those are my final words.
Jacques, what do you think? What is your opinion?
Well, I agree with Mirvat. I think first you have to be comfortable with the easiest solution with the provisional stenting. I think at the beginning of your learning curve, it's necessary to have your senior just behind you and just to be more comfortable. Of course, we have learned from endovascular imaging, and this is probably one of the key at the beginning of the learning curve. It's difficult to evaluate how many procedures are necessary, because I think everybody is different, and the practical skills also. That's my opinion. So
thank you so much. Thank you so much. What do you think, Nicolas?
I think that, well, that first, I think that Mirvat completely and nicely wrapped up the questions. I think that one of the main issue is the volume, because as mentioned by Jacques in his slides, bifurcation represent 15 to 20% of the procedures, and two-stent strategy represent 10% of the bifurcation. So if you are like if you perform 400 PCI per year, that's a pretty huge number, then you will probably do 8, maybe 10 two-stents technique per year. So it's very difficult to be comfortable with all the techniques. I think you have to know all the techniques. You have to get one your favorite one. In my case, I like the tap. That's one of my favorites, especially because that fits well with the provisional approach. And my second approach is the decay crush, when I know that for sure I will use the two stents technique. And I would advise the younger colleagues to start to do bifurcation as soon as possible. It's not that complicated to do provisional approaches. Of course, you have to be mentored. You need the support of intracoronary imaging, but of course, at least just do as many as you can. Do as many side recrossing as you can, just to practice, because when it will be very when you will need it in a case of a larger occluded vessel, then you will feel much more comfortable.
Thank you so much, Nicolas. I will leave Goran to draw the final conclusions of our webinar. Goran, please.
Yeah, thank you very much, Alex. Thank you, Mirvat. Thank you, Nicolas and Jacques. I really enjoyed this 1 hour. It passed really like just a few minutes since we started, and it's already the end. So we definitely need to repeat, because bifurcations are still one of the most challenging lesion subsets. Every time we have a session on bifurcations, there is a full audience and there is plenty of questions like today. And I believe that we need to understand two different approaches. One that is promoted by the European Bifurcation Club, in which provisional is understood as a philosophy, as a strategy, not as a single stent versus two stents, because we start stenting the main vessel, then we evaluate the result after initial pot, because these are the only two mandatory steps: stent according to distal main vessel diameter and do pot to achieve and reproduce natural fractal geometry of bifurcations. And I like this layered approach, because you can stop at any level when you achieve good result. If the result at the side branch ostium is good, you can stop after pot. If not, you can dilate, you do kissing, and then you evaluate again. If the result is good, you can stop after kissing. If still compromise side branch, you can proceed to stent. And then it gives you option to do T, tap, or culotte, depending on the angulation, reference vessel sizes, and personal experience and personal preference. So having second stent implanted in provisional is not bailout and is not complication. Second step is just one of the steps in the layered sequence of stepwise strategy approach to bifurcations. I also understand the other school, more popular in Asia, that high risk of compromising the side branch really deserves, in experienced hands, upfront two-stent strategy, and for those cases, DK crush is really excellent option. So either provisional as a philosophy or planned two-stent strategy for which DK crush really has huge randomized evidence of improving clinical outcome. So I thank you very much for the opportunity to participate. I had really immense pleasure to discuss with three panelists such important complex bifurcations that both our panelists presented, well illustrated, and I learned a lot. And Alex, thank you very much for setting up this webinar.
Thank you so much, Goran. It was lovely hearing all of you. Thank you to the lovely Mirvat. Thank you for her time. Thank you, Jacques. Thank you, Nicolas. And thank you once again, Goran Stankovic. Maybe you are all invited to have another webinar, maybe in the following month. Maybe we'll talk about the left main, but we will keep our cardiologists updated when this webinar will air. Thank you so much for your time. Have a very nice evening, everybody.
Bye-bye.
Bye, thank you.
Bye-bye. Bye, Jacques. Bye, Nicolas.
Bye, Goran. Bye,
Bye,
Mirvat.
Mirvat.
Jacques.
Thank you
See you.
so